Hello, this is Abrar Qureshi. I'm a dermatologist from Brigham and Women's Hospital in Boston, and delighted to be sharing with you our experiences. I'll be speaking to you about some next-generation therapies for psoriasis and psoriatic arthritis, and discussing really some controversies in the management of psoriasis in patients with multi-system disease. We'll also spend some time on developing strategies to manage patients with psoriasis and multi-system disease. In particular, I'll give you an example of a case we saw recently in our combined dermatology and rheumatology clinic in a patient with psoriasis and Crohn's disease in the clinical setting. So the first case is that of a 24-year-old lady who presented to our clinic, and she came in with a history of Crohn's disease for about 10 years, had previously been on therapy for her Crohn's disease with 6-mercaptopurine, and then had been switched to azathioprine subsequently. And the bowel disease was doing very well until she flared about 4 years ago, at which time she was started on intravenous infliximab, 5 milligrams per kilogram, every 8 weeks, with, again, excellent control of her bowel disease. And when she saw her gastroenterologist about 3 months ago, they had noticed a rash that was developing on the scalp. Initially was considered nonspecific. She was asked to keep an eye on the area. And then as the rash worsened and she began to lose hair, her scalp began to become painful and somewhat itchy, she was referred into dermatology. She also had now reported, at the time she came into clinic, a 3 to 4 week history of a rash that was developing on the lips, on the corners of her mouth bilaterally, and involving her legs, and a few lesions were developing on her arms. And this is what she looked like in the next slide. Her scalp was quite heavily involved with thick micaceous or silvery scale. The scalp was boggy on palpation, and she was losing hair in patches. Some of the areas were oozing straw-colored or whitish, almost pus-like fluid. The next slide shows you a picture of the scalp vertex, where you see a large area of hair loss. Now, typically in scalp that presents like this, the first thought that dermatologists would have is psoriasis or a severe case of seborrheic dermatitis. However, we don't typically see alopecia of any kind with psoriasis, and this is somewhat atypical in these patients who are presenting to our clinics with a history of inflammatory bowel disease or rheumatoid arthritis for that matter, who are then put on anti-TNF therapy, are doing fine for an extended period of time, and then suddenly develop new onset psoriasis or psoriasiform eruption. These eruptions are typically quite prominent. They're quite inflammatory. They tend to be associated with hair loss. The next slide shows you an image of this young lady's lower half of her face, and you see an erythematous fissured-like change, almost an angular cheilitis of the corners of her mouth. What is interesting is actually the inside of the buccal mucosa was also involved with superficial ulcerations and what looked like granulomatous changes. And this was diagnosed by our oral pathologist as cutaneous Crohn's or mucocutaneous Crohn's. And then the next slide shows you more classic psoriasis. If I just showed you this image and didn't tell you anything about the patient and you made a diagnosis of psoriasis, you'd be spot on. So this young lady is presenting with a constellation of a psoriasiform eruption with mucocutaneous Crohn's while on infliximab. And it's kind of the contrary situation that you'd expect, because she is on infliximab. Infliximab is an anti-TNF agent, monoclonal, that has been approved for the treatment of psoriasis and psoriatic arthritis. So why is this young lady developing a paradoxical reaction with psoriasis developing when she never really had such skin lesions in the past while on therapy? So this is sort of the setup for our discussion on anti-TNF therapy, and where we'd like to sort of discuss what the options are in terms of management of these patients, and what you would do as next steps if you were faced with a situation like this. So the next slide describes for you the current anti-TNF agents that are on the market in the United States, approved for use in psoriasis and psoriatic arthritis. And I've listed them in alphabetical order by generic name. Interestingly, infliximab is the one at the bottom is the only anti-TNF agent that is given intravenously. And so it is less commonly used by our dermatology colleagues, although those who have access to infusion centers will use this more commonly. And then etanercept and adalimumab are probably the more common agents used in dermatology clinics across the country because they are administered subcutaneously and are approved for psoriasis and psoriatic arthritis. There's some use of Cimzia or certolizumab and then golimumab by dermatologists as well. But all these agents have been approved for the use of have been approved for inflammatory bowel disease, except for etanercept. So etanercept is the fusion receptor. It's in the middle of your screen. It has not been approved for use in inflammatory bowel disease. So our mainstay of therapy remains at least the other 4 agents. And so in a patient like the kind I've described to you, where they have been on infliximab for at least between 2 to 4 years, are now developing a new onset eruption, the question becomes, how do we manage them? How do we manage their new onset skin disease? Is it psoriasis? Because I mentioned to you that some of the alopecia we don't typically see with garden variety psoriasis vulgaris. And then how do we manage their bowel disease concomitantly, and how do we work with our GI colleagues to do this? We are seeing a number of reactions to the anti-TNF agents. I'm just going to enumerate them for you in the next slide, but we won't really be talking about them in much more detail. But just to let you know, we are seeing a number of patients with basically new onset psoriasis, the kind we're describing in this case. We're also seeing psoriasis exacerbations in patients who have known psoriasis, where the psoriasis can manifest with a new morphology. If the patient has chronic plaque psoriasis, they can present with pustular psoriasis of the palms and soles. The rash can also be eczematous or lichenoid and pustular. We are seeing a number of granulomatous eruptions in our patients as well who are on anti-TNF therapy. Typical scenarios, again, are patients who are being managed by our rheumatology colleagues for, let's say, rheumatoid arthritis, are on anti-TNF therapy, develop a rash, appears to be granulomatous on exam, and typically is a granulomatous dermatitis or granuloma annulare-like eruption that responds typically to topical steroids. We have seen a few cases of new onset collagen vascular disease, particularly lupus-like disease, in patients on anti-TNF therapy. And finally, we have seen a number of cases of vasculitides, typically either leukocytoclastic vasculitis or medium vessel vasculitis in these patients. Crohn's and psoriasis are linked, and the question is this patient that's presenting, are they developing psoriasis because they just have a tendency to develop psoriasis by virtue of having the phenotype for psoriasis, or are they developing psoriasis as an adverse cutaneous reaction to the infliximab? So it behooves us to discuss the association between Crohn's and psoriasis and the recent literature in the area. So we do know that the proportion of Crohn's patients who have psoriasis is in the order of between 7 to 11%, whereas the general population has about a 2 to 3% prevalence of psoriasis. So certainly psoriasis seems much more prevalent in the Crohn's population. And of course, we do know that there are a number of shared genetic loci common to both Crohn's disease as well as psoriasis, in particular the interleukin-12/23 pathway. Now, psoriasis has also been associated with increased risk of Crohn's disease, but not ulcerative colitis. And this is a manuscript that we've recently published in the Annals of Rheumatic Disease, where we found that individuals who had psoriasis are at a much increased risk of developing Crohn's later on in life. Certainly we're talking about the opposite scenario here, but this manuscript does link psoriasis with Crohn's. And then this is a paper we published in the Journal of the European Academy of Dermatology and Immunology in 2012, where we found that there were certainly more comorbidities in patients who had Crohn's plus psoriasis that were presenting to our clinics. And more than 40% actually had inflammatory arthritis diagnosed by a rheumatologist. So the controversies are, when we're dealing with a situation where there's a question about an adverse reaction to anti-TNF therapy, is this really a class effect? Will this patient respond the same way to every single anti-TNF agent thrown at them, versus being a more agent-specific mechanism where if we were to switch this patient from infliximab to another anti-TNF agent, let's say certolizumab or adalimumab, would they do better? The other question is, Is the patient being undertreated? We do know that infliximab at least for psoriasis, is required at least every 6 weeks or preferably even every 4 weeks because the skin disease requires more frequent dosing. Versus, is this really a true adverse reaction where if we increase the frequency of the infliximab this lady is getting at every 8-week intervals, if we went up to every 6 weeks, every 4 weeks, would the reaction become more pronounced and actually worsen? And then finally, the other controversy we discuss is, should we support the GI physicians by treating through this reaction, keeping the Crohn's colitis or Crohn's disease at bay by using topical therapy or other means to manage the skin disease versus changing therapy and then basically risking a Crohn's flare. So there has been at least one paper published that we published, and a couple other groups have also written about on this notion of psoriasis-associated alopecia or alopecia areata-like reactions secondary to the anti-tumor necrosis factor alpha therapy drugs. And these are non-scarring alopecias. So we reported a case series of 3 patients who developed scalp alopecia along with these changes during anti-TNF therapy. And scalp biopsies in these individuals showed essentially that there were a number of neutrophils in the epidermis and plasma cells, but more importantly, there was hair follicle-associated changes in the deeper layers of the skin, the dermis, suggesting that there might be 2 processes ongoing in these patients. So in terms of diagnosis, the question then becomes, is this a psoriatic diathesis that this patient is just manifesting now associated with a Crohn's disease versus is this really an infliximab-provoked or associated psoriasiform eruption? So the question is, what would be your next step at this stage? Would you stop the infliximab? Would you continue the infliximab? Would you maybe add methotrexate to the infliximab? Would you potentially add acitretin? Acitretin is a retinoid that has been used frequently in psoriasis, both as monotherapy and combination therapy. Has almost no effect on the musculoskeletal disease, but in this patient, psoriasis may be beneficial. Or would you add phototherapy as another treatment option? Well, it behooves us to, again, think about the diagnosis. If we're thinking about psoriatic diathesis associated with Crohn's, we're talking about inadequately treated psoriasis, we really need to either add an agent to the infliximab or increase frequency. Maybe do reverse order, increase frequency first before adding a second agent like methotrexate or acitretin, versus stopping the infliximab if we're thinking that this is an adverse drug reaction. And really there's no way to tell other than clinical intuition and really asking the patient. And a good question to ask the patient at this stage is if they worsen, if their skin disease is worsening or found to be flaring, closer to their next infusion, meaning the furthest they are away from the previous infusion, and or if they improve dramatically after their infusion does occur. So I've put together a little schematic for you. If you see psoriasiform reactions while on infliximab or any other anti-TNF agent in patients who, let's say, have not had previous psoriasis, the question is, what do you do? Is it because of inadequate treatment, or is it because of infliximab adverse reaction? And if you go down the first path, if it's inadequately treated, meaning it's really a psoriasis diathesis, you would continue the infliximab on the next slide, and then you would. The question is, how would you do it? Well, you could increase the frequency from every 8 weeks to every 6 weeks, or then even every 4 weeks, or you could increase the dose from 5 milligram per kilogram per day per infusion to 7.5 mg per kg per infusion, or even 10 mg per kg per infusion. The max dose that we've used for psoriasis has been in the 10 milligram per kilogram every 4 weeks. Or we can certainly add methotrexate, acitretin, or phototherapy. If we go down the second path, which would be, consider this is because of an infliximab adverse reaction, we would stop the infliximab, of course. And then the question would be, what do we do to manage the patient's, both Crohn's disease as well as psoriasis? We can certainly consider methotrexate with or without an anti-TNF agent, either adalimumab, golimumab, or certolizumab, and I put the doses on the slide for you. In this case, because the patient was not doing very well and the psoriasis was really beginning to bother her and she was losing lots and lots of hair, we needed to discontinue the infliximab. And she was started initially on methotrexate subcutaneously, 10 milligrams a week. A good conversion or formula to remember is that for a 25 milligram per ml vial of methotrexate, each 0.1 ml is equal to 1 pill, or 2.5 milligrams. So each 0.4 ml is equal to 10 milligrams. And then she was also started on concomitant folic acid. She came back, we were seeing her closely every month, and was not clearing 3 months later. So at that point, we added in adalimumab, 40 milligrams, subcutaneously every other week, and she cleared and did very, very well. Her Crohn's disease was doing very well at last follow-up, as well as her psoriasis. She now has a diagnosis of both psoriasis and Crohn's disease. Now, I just want to share with you a brief second case on the same theme. This is a 56-year-old lady who has a long-standing history of Crohn's disease, as did the last patient, more than 18 years or so, and previously was well managed on steroids and 6-MP and then azathioprine, but had been started about 8 years ago on adalimumab, 40 milligrams every other week, with excellent control over bowel disease. And so we started on adalimumab about 8 years ago, 40 milligram every other week with excellent control over bowel disease, but had developed a new rash on the chest, submammary areas, groin area, and scalp, and the rash was beginning to worsen, and her gastroenterologist was puzzled, and so she was sent in to see us. And this is really what she looked like. She had scalp involvement that looked very much like psoriasis, background of erythema with overlying powdery, whitish, micaceous scale. She had a fissure behind her right ear as well as the left ear with erythema and scale. She had lesions developing in the suprapubic area as well as submammary areas. And so this is beginning to look very much like either inverse psoriasis with a slight hypersensitivity reaction. And so in her case, because the reaction was relatively mild, she was willing to try a modified regimen before we switched the adalimumab. In her case, we increased the adalimumab to 40 milligrams every week, and we added methotrexate 10 milligrams per week subcutaneously. And she actually did very well. We also gave her folic acid because she was on methotrexate, and she cleared. So in a nutshell, when faced with these patients who are on anti-TNF therapy, who develop new-onset psoriasiform reactions, it really is critical to really talk to the patient and understand whether they might be worsening with, away from their last treatment, and when they're on, getting therapy, for example, especially an infliximab infusion, which is occurring every 6 weeks, or adalimumab every 2 weeks, or let's say certolizumab every month or every 2 weeks, if their skin is worsening or improving, and that'll give you a hint as to what the next step is. Certainly, if you continue a patient on therapy and they worsen, it's much clearer that they need to be switched, and one can take it from there. I do want to share with you some data. This is a paper published in 2012 in the journal Crohn's Colitis, where they looked at basically patients who actually had Crohn's disease, and they looked to see how many of them developed psoriasis. So 21 of 1294 patients on anti-TNF therapy developed psoriasis, so a much lower rate than previously reported. What was interesting was that majority of these people were on infliximab, and about some of them were on adalimumab. Majority developed Crohn's disease, although about 4 had ulcerative colitis. And the psoriasis manifestations were quite classic. So a number of them, about 1.5 had plaque psoriasis. A little more than 10% had scalp involvement. Some had palmar-plantar pustulosis. And there were cases of pustular psoriasis, gutted psoriasis, and inverse psoriasis, about 5% each. 4 patients interrupted therapy, and only one of them had regression of lesions, but 17 patients were maintained on their therapy and managed with topical steroids. So certainly it can be done in these patients, with the right kind of follow-up and close follow-up. So take-home points, certainly in case of psoriasiform reactions to anti-TNF therapy, class effect seems to be not the case. This seems to be sort of an agent-specific reaction, and with the right kind of follow-up, one can certainly switch to another agent within the class and see good efficacy. Depending on how you want to make the clinical judgment, you can certainly increase frequency of therapy or dosing of therapy if you think that this is under treatment rather than stopping therapy, which would be considered in the case of an adverse reaction. And then we work very closely with our GI colleagues and as well as our rheumatology colleagues when we're managing patients with both inflammatory bowel disease as well as rheumatoid arthritis to really then discuss how best to manage the patient's skin disease. And often working closely with our colleagues, we come upon the right treatment regimen to manage both aspects of their disease. While we're talking about inflammatory bowel disease, it's worth mentioning other Crohn's-associated manifestations that include uveitis, spondyloarthropathy, oral aphthous ulcers, nail dystrophy, granulomatous and neutrophilic dermatoses, and hidradenitis suppurativa. So uveitis can present with basically a scleral injection or a limbal injection. This young lady has an injected right sclera. If you ask her to cover her left eye and look out of the right eye only, she'll note to you that there is blurred, sort of blurred vision. Also, you'll notice that the right eye seems to have slight ptosis. That really isn't ptosis. It has to do with edema around that right eye, which is causing the eye to look slightly more slightly closed. This is an image of a patient who has a limbal injection. There's erythema around the iris, right at the limbus, and another classic presentation of uveitis. And these people need to get to ophthalmology as soon as possible to be started on the right treatment regimen. There's a gentleman who has axial disease, a spondyloarthropathy. His spine is fused in this position. He was on methotrexate for many years for psoriasis and arthritis, and also has inflammatory bowel disease. This is a gentleman who has Crohn's disease, has oral aphthous ulcers, severe nail disease, as well as axial spondyloarthropathy and sacroiliitis on anti-TNF therapy, doing very well. A young lady who has a condition called erythema elevatum diutinum, which is essentially a leukocytoclastic vasculitis. You can see the purpuric lesions on both calves and pretibular areas occurring concomitantly with large nodules. These are almost rheumatoid nodule-like lesions, but this lady has Crohn's disease, and these nodules on the heels and both feet are essentially granulomatous and neutrophilic in nature. And these patients do very well, typically in a combination of anti-TNF therapy for their Crohn's disease, along with an anti-neutrophilic therapy such as colchicine or dapsone. And finally, hidradenitis suppurativa. It's worth remembering these patients do tend to get quite severe hidradenitis in the groin area, in the perianal area. Disease is quite debilitating, very painful, and they can be misdiagnosed as either anocutaneous or rectocutaneous fistulae, but these tend to be long-standing lesions of which are basically inflammatory acneiform lesions that tend to break down, ulcerate, and then form sinus tracts. And again, anti-TNF therapy seems to be the mainstay of management for these patients as well. Thank you for your attention.